Hi, I'm Tom Marino. At Cohn-Resnick, we believe that all citizens need to be informed about the issues that affect their daily lives. That's why we're proud to support the programming produced by Caucus Educational Corporation and their partners in public television.
Funding for this edition of One-on-One with Steve Adubato has been provided by Investors Bank, the Russell Berry Foundation, Fedway Associates, Inc., PSE&G, committed to improving New Jersey's economy and strengthening its communities, the law firm of Gibbons PC, and by St. Peter's University, the Jesuit University of New Jersey.
This is One-on-One.
When you first heard that they were doing Charlie Rose and Gayle King, didn't you go, what?
People like laughing at others, so I don't mind if the other is me.
See, you go right into the character. That's what it is.
I'm bringing families together a half an hour each week. Man, I'm doing something special.
And so I do feel successful.
Hi, I'm Steve Adubato. I want to introduce you to Dr. Randy Deger. He is a Gynecologic Oncology Specialist here at Virtua. Doctor, I want to welcome you. Actually, we're at your place, so you can welcome us.
Welcome.
Doctor, we have technology behind us that you're about to explain to us. Now, talk to us about your specialty, first of all. Who do you treat?
Well, I'm originally trained in OBGYN and have a subspecialty in gynecologic oncology. So the majority of my patients have cancers of the female genital tract.
Now, the technology we're talking about here, this robotic-assisted surgery, right, that we're talking about here, this Da Vinci, if you will, surgical system, it's changed dramatically how you treat your patients.
It has. Clearly, the laparoscopic technique, or the minimally invasive, has been around for quite a period of time. The FDA did approve this technology for GYN use in 2005, and since that time, we have used it in many, many different circumstances for GYN patients.
Now, before you go over there and actually give us a demonstration, Doctor, who is it, or which women are the best candidates, if you will?
Well, because of the small incisions and the population which is becoming larger, and particularly endometrial cancer patients tend to be larger patients, this technology...
No, that's endometriosis, someone with endometriosis?
Well, endometrial cancer first.
Okay.
They tend to be larger patients, and this technology has helped them recover quicker, smaller incisions, avoiding large, big incisions, making actually their return to life much more rapid. The disease that you're speaking of, endometriosis, can be a very, very difficult disease to manage surgically, and the majority of those patients will oftentimes require a large incision. However, with this technology, with expertise, it can be done through a laparoscopic approach, if you will, or a robotics approach.
Am I going over there and showing us?
Absolutely.
By the way, as the doctor goes over, just want to remind folks that he's in charge. The doctor is in charge. Sometimes people say, oh, wait a minute, the robot's going to do it? No. The doctor is in control of the robotic equipment, and as he does it, he's going to show us how this works. Now, the doctor, as you can see with our camera work, is moving. Doctor, describe what you're actually in control of right now.
So, Steve, I have control of 4 arms, and 3 of the 4 arms have instruments, and one of these has a clutch. So I'm always in control of 2 of the 3, as you can see. In addition, I have control of the camera, which allows me to move in and out from the surgical field.
The camera's right here, right, team? Right? Doctor, just to give a sense of scale, is it okay, I don't want to hurt myself here, is it okay if I stick my finger in here to give a...
Absolutely. Come on over here over this red cone, Steve, and I'm going to hand you this rubber band.
Where can I come in, over here?
You're coming from the back here and just come right near this red cone.
Is that good?
That's perfect. And as you can see here, our audience can see the relative size of the end of this instrument compared to the rubber band and your finger.
That's fascinating.
Now, because there are several things about the robot which is different from laparoscopic. One is you can readily see how the instrumentation articulates in such a way as my wrist does. And this gives us a much better ability to move into tight spaces, close anatomy, as you can see here, for example, moving things over in this direction. When you have a straight laparoscopy, the instrumentation is defined in 2 planes, in and out and sideways. That's it.
No wrist?
No wrist.
So define that again, doctor. So laparoscopic technology, not like this, does not have the wrist capability.
That is correct. And limits your ability actually to get into those tight spaces, which is really the big advantage of robotic surgery. In addition, you can see that I've had 3 cups of coffee this morning, and these instruments are not shaking at all. And one of the things that the robot does is it takes the shake out of the hand. So the tremor is absolutely reduced to nothing.
It takes the shake out of the hand?
The tremor, yeah. There's an inherent tremor which surgeons tend to have sometimes. As you can see, I'm absolutely...
You're doing that on purpose?
I'm doing that on purpose, right. But you can see here, as I'm holding this right now, you don't see any shake at all.
Because?
That's just the way the technology has been designed. Now, the one disadvantage is, and this is what you have to get used to as an operating surgeon, and we learned this during our training, is that you can't feel how strongly you're either touching something or how weakly you're touching something. So for example, when I pull on this, I don't have any what we call haptic response in my right hand. I am pulling on this, but it feels the same whether I'm pulling way up here or whether I'm just pulling a little down here. So a lot of the surgery that we do is predicated on our ability to look at the tissue blanching,
right,
or quite honestly, just the experience that we get in doing this procedure.
So experience is huge. Come on back over here, doctor. First of all, that was fascinating what you just showed us. But one of the things I want to get at right away, you talked about all the advantages. Okay, I put my finger in there, and it was amazing, the scale, the difference, and what is it? Is it 10 times bigger?
10 times.
10 times.
Yep.
But the one thing you said that I know people need to understand is you said that one of the challenges has to do with the what you could feel and what you couldn't feel. Would you not what language did you use?
Was haptics.
Haptics. What does that mean?
Haptic response. Well, in open surgery, you're able to feel how the needle, for example, goes through the tissue. In this particular circumstance, we rely on our experience as well as the excellent visualization to protect us from that particular circumstance.
So for the patient's perspective, which is what we're concerned about, is how does the patient, how is the patient protected there?
By the surgeon's experience, clearly.
So the patient knows, based on that experience, how hard they're pressing and how hard not to press, right?
A robotic surgeon has that training to prevent any kind of problems from happening.
So the key is the training.
That's correct.
The key is the experience.
That's correct.
What does this do for most patients in terms of the recovery?
Well, the majority of my patients leave the hospital in 23 hours. So if I do a surgery on a Monday, by Tuesday afternoon the patient is home. That would never be the case with an open procedure. You're looking at a 3 or 4 day hospitalization at a bare minimum, and also the complications that are associated with a large open wound and other potential medical problems the patient may have.
Most patients respond well to the idea of this robotic surgery, or how much you educating them is involved in the process?
The majority of patients are delighted with the recommendation. Once in a while, a cancer patient will be concerned with the inability of the surgeon to get their hand in the abdomen to feel all around to be sure there is no other cancer. That's a rare circumstance, and if you choose your patients correctly, you almost will invariably not be in that situation.
Again, you called yourself an old dog, your words, not mine.
Correct.
More importantly, what it really means is you've seen a lot.
Correct.
For you to see this right now and to see the possibilities and the challenges, what does it mean for you moving forward in terms of treating your patients? How excited are you?
I think this is fantastic. This has been a major addition to my ability to take care of my patients, and certainly they are most grateful at the end of the day when seemingly the outcomes are the same long term with a much more rapid return to life.
And finally, the possibilities you see ahead?
I think we're going to see it in other malignancies as well.
You do?
I do. I think that it's a matter of time, but it will take time and we will see it.
Dr. I want to thank you for joining us and sharing about this important technology and the possibilities, but also helping to educate people.
Thank you, Steve. My pleasure.
Thank you. Stay with us, folks. We'll be right back.
If you would like more information on this program, or if you'd like to express an opinion, email us at info@caucusnj.org. Visit us online at oneonone.org. Or find us on Facebook at facebook.com/Steve Adubato, PhD.
Monique King-Viehland is the president of Campus Gateway Development, Inc., connected with NJIT, New Jersey Institute of Technology. Good to see you, Monique.
Thank you. Good to see you as well.
This is a fascinating initiative. Put this in context for us. The Campus Gateway Development Project, 10 years, $1.3 billion.
Yes.
Where is it? And because we're seeing in a lot of different states, but even for folks in New Jersey, NJIT is a very important academic institution in Newark.
Yes.
And this project is an economic development project. Where?
It's in the University Heights section of Newark, and it's actually one of the sections where there are a lot of different colleges and universities. So we have Rutgers, we have NJIT, we have Essex County, we have UMD&J, and what we're trying to do is an initiative that builds on the momentum and the assets of that 40,000 plus people coming into the city every day.
Now someone might say, okay, why would the New Jersey Institute of Technology, why would an academic institution of higher learning get involved in business, economic development? Why is that your business?
You know, it's our business because we're a neighbor. We live in that community. We're in that community. We've been there since 1881, and we'll continue to be there. You know, anchor institutions like NJIT aren't going anywhere. So our focus and our future and Newark's future is all linked together. And so it's important for us to make sure that we're doing as much as we can and taking a proactive role to continue to see the city redevelop.
Monique, let's break it down a little bit. We talked to your president, Dr. Bloom, who's been advocating this project, and his predecessor, Bob Altkirk, did the same thing. So now let's put it in perspective. 4 phases, right? We got 4 phases.
Correct.
Jackie Cook, our producer, we got some pictures of this, Jackie? We're going to, as we show some pictures of phase 1, under construction right now. This is the Warren Street Village, correct?
Yes.
Talk it through.
So this is the Warren Street Village. The view you're seeing is the perspective of a rendering from Raymond Boulevard. Warren Street Village is an $80 million project. It's on approximately 3 acres, and it's 214,000 square feet. The building in the far back is the Dorman Residential Honors College building.
The Residential Honors College, 6 stories.
6-story building, 4 floors of residential living, 1 story of office, and the bottom has dining facilities, fitness center, and a convenience store.
Why is it so important to have such a facility? By the way, what are we looking at right there?
This is actually the project last week under construction.
For real?
So yes, it's going up pretty fast.
Wow. That's wild.
Yeah.
By the way, very tough to get financing for this, no?
That's correct. Yeah, we tried to pursue the Urban Hub Tax Credit Program at EDA. You know, clearly that program was oversubscribed, and then EDA sort of went into a moratorium.
Economic Development Authority?
Economic Development Authority went into a moratorium. And actually, I was impressed. What our board ended up doing was deciding that this project was too important as the first phase of Gateway and too important to stop. And so we actually went out and did tax-exempt bond financing for the project.
Talk about commitment.
Exactly.
That's a real commitment.
Exactly.
And you know, as we talk about phase 2, which is planned for spring 2014, what's interesting to me is this is huge in terms of, I mean, growing up in that neighborhood, knowing Newark very well, NJIT, very smart students, you know, a premier academic institution. But being connected to the neighborhood wasn't always the thing. You know, there was always some, they're not really part of the neighborhood in the way you're talking about right now. That's a big part of this.
That's right. Phase 2, I think, was most interesting, and it excites me even more than phase 1, because phase 2 is really the first phase where you'll see the boundaries between campus and the community dissipate.
What do you mean?
Phase 2 is all about creating a better space, not just for the students and faculty and staff at NJIT, but also for the residents of the University Heights community. It's going to be a mixed-use development. It's not focused on student housing. It's hopefully going to have a grocery store.
Hold on, let's talk about it. A grocery store. Why,
Yes.
for folks who don't know this section of Newark, why is having a grocery store such a big deal?
You know, well, 2 reasons. One, we know that for a long time Newark has been a food desert. And although we are starting to see some retail come in terms of grocery stores, we still are underserved and could use more grocery stores. The other thing is we did a large-scale surveying process of the community before we started this to look at what they needed, and one thing that came back as a resounding yes was that they needed a grocery store in the community. So we know this isn't just going to serve NJIT people, this is going to serve the larger University Heights community, and I just think that that's tremendous.
The other thing that's so interesting here is retail stores. This is all in phase 2, folks. Retail stores, more housing?
Yes, more housing, non-student housing.
Oh,
so this is
non-student
not
housing.
affiliated housing. We are not building NJIT student housing. We are looking to have the private developer build non-affiliated housing that hopefully will attract some young professionals to the area.
And why is a parking garage so important?
Parking garage is critical. We lost some parking when we did phase 1 for NJIT, and also phase 2 is on a lot that's currently utilized by St. Michael's Medical Center.
Right.
So we're replacing both of those parking and providing parking for the retail.
Now, we were talking about this before we got on the air. You grew up and know Trenton very well.
That's right.
And I actually grew up just a couple blocks away from where you are right now at NJIT. Places like Newark and Trenton, right? But in this case, Newark in particular. Why is it so important that, I mean, this is referred to as University Heights. You know, you got Rutgers Newark there, you have NJIT, you have Essex County College, right? Why is it so important that academic institutions like NJIT take a leadership role here in the community?
I think it's important because we're here and we're going to be here. We're not leaving. We're not going to relocate our corporate headquarters. I mean, Newark is our home, and it's important that we want our home to be the best that it can be. And we understand that the relationship between us and Newark's success is one that's synergistic. So if we want to continue to grow, we want to continue to be successful as a premier technological university, we also need to make sure that Newark continues to grow and be successful as a city.
And the reaction you've gotten so far has been?
It's been very positive. We've gotten very positive reaction from the city, from the community, and from the students and faculty of NJIT.
You know, it's so interesting. Folks who, this is part of the quote-unquote Central Ward in the city of Newark, which was ravaged by the riots in 1967, which, you know, for those of us who were little kids at the time, remember, you never forget that. This has the potential to bring folks from the Central Ward who've been there a long time and NJIT closer together, no?
I agree, yes. And I think the process that we undertook is central to that. I mean, we started this back in 2006, and it was a long community development process. So we're doing this with our stakeholders. This isn't a project that's happening to University Heights, it's a project that's happening with the University Heights neighborhood.
18 months, come back and give us a progress report, Monique.
Will do.
Congratulations, keep it up.
Thank you.
To our partners at NJIT, thank you. I'm Steve Adubato, stay with us, we'll be right back right after this.
If you would like more information on this program, or if you'd like to express an opinion, email us at info@caucusnj.org. Visit us online at oneonone.org. Or find us on Facebook at facebook.com/Steve Adubato, PhD.
There he is, Mchael Tozzoli, Chief Executive Officer of West Bergen Mental Healthcare. Good to see you.
Nice to see you, Steve.
Tell us what exactly your organization is and does.
Sure. West Bergen has been in existence exactly 50 years this month, actually. Community mental health center that started with a handful of people coming together to put a mental health center together. 50 years later, we employ 250 people, and this year we'll touch just about 4,000 lives. You know, some of the areas I want to focus on, we're doing this program in mid-February 2013. You know, the horrific shooting in Connecticut will play on our minds forever. Indeed.
But the issue of youth depression, the issue of mental health for young people, it's a big area for your organization.
It is.
Why don't we know more, and why haven't we done more for young people suffering from mental illness?
It's a great question, and just as I said a minute ago that we touched 4,000 lives, I'm very proud of that number. Having said that, that number should be 8, 12, 16, 20,000 lives. We are really just touching the very top of the cake. Very little in terms of education, very little in terms of people coming in. And the statistics are clear. People come in, only 1 in 4 that need treatment will actually walk through our threshold.
But in terms of children, are more children suffering from mental illness, depression, than we realize? Without question. Suicide is the second leading cause of death for kids 14 to age 23. Accidents is the only thing that kills children more. It's more than disease, it's more than all the other diseases actually put together. Mchael, why aren't we picking it up?
Schools, I think, have been slow to the table. I think that in the last 4 to 5 years that has changed significantly. I think we as a field have been slower to actually get out there and educate parents. I think we're...
Excuse me, educate them to do what? To look for what?
To come and talk to us. I always say this, small fires are much easier to put out than big fires. So if your kid is not doing well, sleeping too much, not sleeping enough, really not doing well from an emotional perspective, think about bringing them into West Bergen or any of the other wonderful resources that are out there. Small fires are much easier to put out than big fires.
Signs. Again, by the way, log on to the website you see on the screen right now. We're here to be a resource for the community. Your kid is saying that he or she is being picked on at school consistently. Sign?
Without question. Of potential depression, potential anxiety. Risk is very high with bullying. And it's not just the playground. It's no longer just the playground and the school cafeteria. It's the computer, it's texting.
Cyberbullying?
Cyberbullying is a big issue and getting bigger, by the way, much bigger.
Well, what's the correlation then between cyberbullying or any sort of bullying and mental health issues?
Big correlation. If you are a child that is being systematically, repeatedly told that you're worthless, if you are a child that's repeatedly being picked on in whatever way, you are much more likely to be depressed, to be anxious, and to think about doing something that's more drastic.
That's true.
Without
I
question.
have a sip of water.
Yeah, sure.
I'm thinking about this. Asperger's. I hear people talk about Asperger's a lot, and I know that your organization is very helpful in terms of Asperger's services. What is Asperger's, and why do so many people not know what it is or misunderstand what it is?
Asperger's is part of the autistic spectrum disorder. So autism, big topic you hear a lot about in the last probably 2 to 3 years. If you think about a bell curve, on the one end of the bell curve is the classic Rain Man, no language, really severe autism. All the way at the other end of the spectrum is Asperger's syndrome. Those are clients that have autistic-like disorders. The most prevalent part of the issue there is that they don't get normal social interaction. So they don't get verbal social cues, nonverbal social cues. We communicate with each other about 80%, the data tells us, using nonverbal cues. They don't get that. It doesn't come naturally to them. It's likely that that part of the brain didn't develop. We don't really know that for sure and probably won't for a while.
And your organization helps.
We do.
In that area.
We are the largest provider in the tri-state area of mental health services for people with Asperger's. We do it in a number of ways. The largest way that we do it is through social skills groups. In any one group at West Bergen, we're doing 40 groups full of kids, full of adults with no replication.
Let's talk about coverage here. Because it actually, you were referred to us by some folks that we talked to at over at Horizon. So I'm curious about this. A lot of people, I've actually heard people say that they would love to access mental health help. I'm not covered for that. Imagine that discussion. Like mental health is like if they had cancer, well, I'm not going to get. But they go, that's not the same as cancer. Oh, it's not, but
the stakes are high, Steve. The stakes are real and the stakes are high.
Let's talk about, I mean, again, everyone has their own coverage. But
coverage can be inadequate. What we're seeing with the current insurance environment is that insurance companies are really pulling back, although they shouldn't under the law. In effect, they are. And treatment just is harder for them to access. Come into West Bergen, certainly we would utilize your insurance, but most people that come into West Bergen have some type of sliding scale, some type of reduced amount of fee so that you can stay as long as you need to stay. Because typically an insurance company will dictate a certain number of sessions. 20 is a very typical model. Imagine an oncologist being told, the breast cancer is bad, your patient can see you 10 times and only 10 times. On the mental health side, it's really a fallout from stigma, actually.
And it's interesting, in the minute we have left, we actually talked to Governor Christie about this in an interview we did, and I'm sure hopefully a lot of folks saw it from New Jersey Performing Arts Center. And he actually talked about this piece. He said the stigma.
He did.
He said, how dare we treat it differently than cancer? That's what made me think about that. And if we don't deal with it, real quick, 30 seconds left, what are the consequences?
Stigma. Without dealing with it, suicide rates will increase. They will get worse. Depression, much worse. Kids that have emotional and mental illness have a 50% dropout rate.
Are they potentially more violent? I mean, could they potentially be? I don't want to be an alarmist, but
we don't want to tie those two together. But know that all the issues that we've been seeing, Connecticut, beyond that, the one thing that is consistent across the board is that mental health treatment would have helped without question, without any doubt.
Mchael Tozzoli, Chief Executive Officer, West Bergen Mental Healthcare. Your organization is doing important work. Please keep it up. Thank you, Mchael.
Steve, thank you.
Thanks for watching. Now let's continue the conversation about this and other important topics and issues on Facebook. Visit my page at facebook.com/Steve Steve Adubato, PhD.
One-on-One with Steve Adubato has been a production of the Caucus Educational Corporation, celebrating 25 years of broadcast excellence. Funding for this edition of One-on-One with Steve Adubato has been provided by Investors Bank, the Russell Berry Foundation, Fedway Associates, Inc., PSE&G, committed to improving New Jersey's economy and strengthening its communities, the law firm of Gibbons, P.C., and by St. Peter's University, the Jesuit University of New Jersey. Promotional support provided by the Star Ledger and NJ.com, Everything Jersey, and by NJ Biz, All Business, All New Jersey. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. One-on-One with Steve Adubato has been produced in partnership with St. Joseph's Healthcare System.